Good morning. My name is Adrian Park, and Ramon and I will be co-chairing this session. This session is a bit of an interesting departure. Brian Duncan's put together a marvelous program this year, showing some real imagination and creativity. And the focus of this session is going to be more on surgeon safety and surgeon well-being. And this is a topic that I think that we have ignored for far too long, not only to our own peril, but perhaps impacting our patients more than we realize. Before I start the session, I would, like I've been reminded, to tell you, any of you who sat through the previous session and didn't go out and get your cards re-scanned again, you apparently won't get credit for this session unless you get your cards re-scanned. So that's just a point of information. I want also to welcome our webcast audience, and when it comes to the time for discussion of this session, we will be entertaining questions from our audience here as well, obviously, as the webcast audience. So we look forward to their engagement from all around the world. I would like to, I'm going to lead off this session, and if I can have the slides, please. My focus initially will be on ergonomic and a brief discussion of musculoskeletal injuries related to minimally invasive surgery, and suggesting that this is a larger problem that we may have been aware of previously. My disclosures are, as you see here. And as I said earlier, there are issues with regard to surgeon well-being, whether it's physical ergonomics and stress, mental or cognitive ergonomics and stress, that we've not really addressed meaningfully. And I hope through the course of this session we'll be able to at least bring you to some degree of awareness of the kind of work that's being done, and probably perhaps raising more questions than we will answer, and stimulating further discussion and hopefully research. I'll just start very briefly by defining some terms, trying to set the context a little bit for this discussion, and then discuss the data, which is very, very paltry at this point in time, and then we'll say, look at maybe what some next steps might be. So when we look at ergonomics, this has really not been the domain of surgeons and surgical research, other than a few pockets and a few laboratories around the world. But in its essence, ergonomics, derived from its Greek origins, really means the study or the natural laws of work. Practically, what it really speaks to is understanding, and then understanding the relationship between humans and their work environments, and then trying to minimize risk factors that exist and increase efficiency. So it's really the study of our workplace and how we interact with our work. The challenges, the advent of laparoscopic or minimally invasive surgery has posed some fairly unique challenges to us, and many of you, if not all of you, are familiar with these. When we became separated from our target anatomy, as we are in minimally invasive surgery, in open surgery, we make an incision, we have direct visual contact with our target anatomy, we touch it, our visual access, what we're looking at, is in alignment with our motor or working access. In laparoscopic surgery, that's not the case at all. We have ports through which we introduce instruments. We have very limited degrees of movement compared to open surgery. Our movements at the outset are very counterintuitive. There's the fulcrum effect. We want to move our end effector to the right-hand side, we actually move our hands to the left-hand side, and vice versa. Force transmission in laparoscopic instruments is about a fifth or a sixth of what it is in open instruments. So we end up having to crank harder on these handles to get the same kind of grip that we want. The haptics are obviously hugely diminished in the world of minimally invasive surgery as opposed to open surgery. And so we have been offering these marvelous operations to our patients' benefit for so many years now, and we ourselves have been having to adapt, often holding our arms in static, uncomfortable, and unhealthy positions for extended periods of time. The idea of being separated visually from our target anatomy also has brought a burden on us. We are working in 3 dimensions, obviously, off a 2-dimensional image. As I said earlier, our visual axes, what we're looking at, is rarely aligned with how we're working. We're often looking in one direction and working in another, and these issues also take a toll. At the University of Maryland, we had established a lab, and we looked at many of these issues in detail. And I don't show this slide to do anything other than to alert you if this isn't an area that you've been working in before, the kind of things that are involved in this kind of research. So motion analysis, extensive motion analysis equipment and study, the use of force plates both in the lab and in the operating room, EMG systems, and even different other types of eye tracking type systems. These are very expensive labs to establish, and there's just not an awful lot of them either in this country really or around the world at this time. And our interest has been to try to study essentially surgical movement, and then try to categorize beyond that. What we've been trying to do is to categorize the surgical workspace and surgical workflow. Again, this isn't the kind of stuff that headlines meetings and people get all excited about, but it's important work, and there's been precious little of it done through the years. Now, just to illustrate this fact, this is a smattering of things that we've published over the last few years that really most of you haven't read. And the reason I put this up here is that there are several centers. I'm not doing this to toot our horn. I'm saying there has been some good work done, and the panelists you'll be hearing from today have been contributors to this work. But I realized a year or 2 ago that what we probably needed to do was to come at this a different angle to try to get folks' attention and to sound this clarion call as to this impending problem and possibly epidemic of surgeon injury. And so looking at the background at what kind of surveys had been done or how well we understood surgeon well-being in this regard, looking to the literature, there's a few names that often pop up, and one of them is my colleague here, Ramon, who contributed hugely to the early literature on this subject. And when you look at that literature, most reported rates of injury or symptoms, whether it's in the upper extremity, neck, low back, in the order of 10 to about 20% reported injuries. Now, most of these studies that Ramon and his team had undertaken were probably over a decade ago at this point. So with this in mind, what we wanted to do a couple of years ago was really look at the current state of affairs with technique adoption rates and minimally invasive surgery being what they are now, surgeons having been doing this for many, many more years now. We wanted to do a broader and a fairly extensive assessment of surgeons and how they're doing ergonomically. So this was really an international survey study. It's been presented previously, but we looked at all these various demographic factors that you can see here, fairly standard type things we looked at. And then we broke down, I think this is then we broke down the symptoms that we were looking at and then locations in fairly great detail. And so what we found, and I'm not going to go through the whole thing, but what we found, we had 300 surgeons ultimately responding. It was a very detailed survey, so we thought this was a good number for this detailed a survey. Average surgeon was about 44. Most of them were male, reflecting the demographics in the profession, and most of them were right-handed. The average caseload of laparoscopic cases was over 200, and the minority had actually had any fellowship training at this point. One of the questions, really to cut to the chase, that we asked in this survey is, have you had any discomfort or physical symptoms that you'd attribute to performing this surgery? And to our amazement, 87% of participants answered in the affirmative. This was a fairly, I knew there was an issue out there, but this was a fairly stunning response. Now, this is a busy slide, and I apologize. The only reason I put it up here is that using a threshold of a previous kind of understanding of what the problems was, the percentage of surgeons suffering symptoms or describing problems, setting that threshold at 20%, when we looked at a matrix of all the data we collected here, you can see, although it doesn't stand out too well, but the green numbers populate very extensively this table to show that most of the symptoms we're looking at now exceed, in their reporting, now exceed a previous threshold that was reported. So this is a problem. We found that these symptoms significantly correlated with increased caseload, and this again stands to reason, and that surgeons, interestingly, who had undergone MIS fellowships had a significantly higher rate of injury or reported injury and symptoms than those who had not. This also most likely correlated with increased caseload of more advanced MIS cases. So, without going into all the details from that study, one of the conclusions we made is that well, as you see here, and I'd mentioned previously, laparoscopic technique adoption rates have risen and will continue to rise, and this is a good thing. This benefits our patients tremendously. 87% of surgeons who regularly perform minimally invasive surgery suffer some form of operator-related symptoms or discomfort. And it appears to be caseload volume related. Obviously, more studies are warranted. We need to be looking at improvements on all levels in the surgeon-patient and surgeon-technology interfaces. And in a time when we are facing really potentially significant manpower issues and surgeon shortages, when we look at the boomer population, the aging population, the numbers of surgeons coming into general surgery or many of the surgical professions, the last thing that we can afford as a society is shortened career longevity. And it's very interesting to note that when this study in its fullness was presented at the college a year or two ago, I've never had more of a response, kind of groundswell of testimonials being sent to me or called or emailed to me. It was remarkable the number of surgeons who we don't like to admit weakness. We don't like to admit that something may impede the conduct of our professional duties, but on a one-on-one, more intimate basis, an overwhelming amount of testimonials of folks who are suffering based on their work. And since then, there have been other studies coming out. This was published last year. This was a study of surgeons and gynecologists in Sweden. You can see here 70% of those who responded described one or more symptoms, mostly low back pain, but a lot of headaches and visual discomfort as well. The findings were related to longer workloads as well as aging, and females had more symptoms than males. We didn't discover this in our study, but this was reported in this study. It was a study from Hong Kong of general surgeons. Not a very high response rate in this more limited study, but again, you see these numbers that are alarming of those who responded, symptoms extending from 50% of the time to 82–83% of the time. And again, attributed to the sustained and awkward postures that are often associated with not just minimally invasive procedures, but longer open procedures. And then finally, a recent study published in Surgical Endoscopy, limited in the number of those involved, but an interesting study in that it was a prospective study and actually using surface EMG, recording erector spinae muscles, deltoids, and trapezius, comparing open laparoscopic and endovascular procedures, and finding a significantly higher muscle activity in the erector spinae muscles and upper trapezius with open cases versus either endovascular or laparoscopic cases. And interestingly, overall in this more limited study, reporting similar degrees of musculoskeletal symptoms between open and laparoscopic surgery. So never had felt that at the outset that this was just a problem focused or limited to minimally invasive surgery. So finally then, Just a few final thoughts in conclusion. I use the golf swing analogy. We can go and have our golf swings analyzed and improved and calibrated. We can have our tennis backhands analyzed and improved and calibrated. We can't even tell you what ideal surgical posture or movement looks like. And we can't change what we don't measure or what we haven't really meaningfully begun to measure. So it's a little bit of a sad state of affairs that we can improve our golf game a whole lot more objectively and scientifically than we can our workaday surgical activities. I think that there are many more stakeholders in this issue and in this problem than currently realize that they are stakeholders. And part of what I've been doing is trying to spread that message. This is not just an issue for surgeons. This is an issue for all of those who are involved in healthcare policy, resource decision type making, and far beyond just a parochial or provincial surgical issue. And I'd finally say that, as you can see here, the flip side of the paltry data and the very early days that we're in this study is that there's wonderful opportunity, and for young surgeons and particularly academic surgeons, I say there's great opportunity. This is a new area. We welcome bright and energetic young minds to join this work. Funding opportunities right now are a little bit of a challenge. This hasn't really been recognized far and wide enough as an area that requires funding, but I think that will change in the near future. So my hope with this is to set a little context for the presentations that will follow, and hopefully stimulate some discussion afterwards. Thanks very much for your attention.